to our schedule. I'm Nancy Lumley, President of the Board of Directors of Local Council of Women, and we're very appreciative of your attendance this evening to our fourth session in our End of Life series. The first session that we did all the way back in January was entitled Facing Death, the Reality. The second program was Who Speaks for Me? The third, How to Begin the Conversation when either explaining to your loved ones the plans that you have made or convincing someone else to consider making those plans so he or she would have a voice when unable to speak for oneself at that particular time. Tonight we want to focus on the caregiver and the care needed for that individual. We have with us a panel of individuals who will share their expertise and knowledge. And I'm going to turn the program over at this point to Leah Iverson, who will be first on the agenda and will introduce our other participants. Questions are always welcome. If not during, then certainly at the end of the presentations.
Hello, and thank you all for coming tonight. My name is Leah Iverson, and I am the social worker with IU Health in the home care department. And tonight on the panel, we also have Mary Boutain, who is the Director of Strategic Initiatives at Area 10 Agency on Aging, Catherine Boltman, who is a medical social worker with the IU Health Palliative Care Team, and Kathleen Weber, owner and operator of Better Day Counseling and Consulting. I just wanted to give a brief overview of the importance of this topic because I felt like there should be some kind of intro before we get started in what we all do in the community for caregivers. The role of a caregiver is pretty big, and when they start caring for a loved one, it can change a caregiver's life pretty drastically. Not only does a caregiver take charge of the hands-on care needed, but he or she also takes charge of all the tasks the loved one used to do in the household and for him or herself as well. A caregiver quickly becomes the nurse, the home health aide, physical and emotional therapist, the cook, a cleaner, the accountant for the household, the contractor, you name it, it falls on the caregiver. The enormous weight of this role can significantly affect the caregiver, and so now caring for the caregiver is actually a public health concern. So I wanted to share just a few facts from the Center for Disease Control about how overwhelming caregiving can be for us all. I'll highlight just the bolded statements and move on for the rest. If you want the actual statements, they're back there on the slides. First of all, a shocking statistic is that 90% of long-term care right now, as of 2008, has been found to be provided by unpaid caregivers. Out-of-pocket costs for caregivers is really quite extreme, with in 2007 it averaging around $5,000, plus people having to reduce their work hours or have a complete job loss because of the caregiving role. Caregivers also find it difficult to manage the time for themselves, the stress, and just the general balancing of work and family responsibilities. But then at the same time, they tend to rely on prayer, which about 73% said they did, talking with others, seeking advice from other caregivers, and then reading and looking at resource materials. Also, kind of shockingly, is that about half of caregivers said their health had gotten worse due to caregiving. And not only did their health get worse, but it affected their ability to care for their loved one. Similarly, caregivers said that they don't go to the doctor because they put their family's needs first, the care recipient's needs first, and more than half said that they don't have time to take care of themselves or they're just too tired to do so. So this brings me to the last shocking fact, and this one is from the National Caregivers Alliance group, that those caregivers aged 66 to 96 experiencing some kind of caregiving-related stress actually are more likely to die than those of non-caregivers in the same age range. So that's a pretty significant statistic, I think. So one thing to be thinking of, if you're a caregiver, if you know someone who is, what are the symptoms of caregiver burnout and being overwhelmed and stress? If you feel depressed and hopeless, if you keep getting sick on a repeated basis, find yourself maybe relying on alcohol too much, or in a lot of cases where someone's prone to an addiction, it could be even pain medication or anti-anxiety meds, being irritable or having increased conflicts with family and friends, not seeing your family and friends, or having many outside interests, and then just not caring for yourself. So with that said, the panel tonight is here to provide you with resources, hope, and support so that you can hopefully leave with a little bit of energy and tools in your pocket. So we will begin with Mary with Area 10.
Okay, I passed the first test. I got down the stairs without falling, so that was good. I'm from Area 10. It's nice to see you all this evening. I've been working at Area 10 for 5 years, but the last 2.5 years, I was a caregiver of my partner's mother, lived with us for the last 2.5 years. She passed away in May. But this is a very personal topic for me as well. I enjoyed my role as a caregiver, but I do know that it does take some work. So here's some resources for you. The Area 10 Agency on Aging is... This is our mission statement, that we like to provide resources and solutions and connections to help people have more fulfilling lives. Let's see. Area agencies on aging were formed in the 70s, and we've been around since then. We are a non-for-profit. Some of the area agencies on aging in Indiana are not. They are maybe put in an economic development corp or in Vincennes. It's part of the university there. So they're not all created the same. However, we do all receive funds through the Older Americans Act that provide resources like nutrition, aging and disability resource centers that have information and resources for everyone. But there's an area agency on aging everywhere in every state. So if you're caring for someone in another state, you can go online and find the area agency on aging that serves the area or serves the county in which your loved one lives. Try this. Oh, good. Fixed that, didn't I? Okay. Let's see. Here we go. There. So like I said, all of the area agencies have an Aging and Disability Resource Center. So that's often that first call for help. We answer phone calls all day long. I think mom needs more help and I don't know where to start. What's a power of attorney? Where can I go to get help for this or that? What I think we need some in-home services, or I would like a referral to something for housing or something like that. So we answer calls all day long about stuff like that. So we have a lot of resources, and we maintain a very good database, local database of the resources that are available. Some of the things that we provide in that is the State Health Insurance Assistance Programs, the SHIP program. We do a lot of Medicare counseling. When you first go onto Medicare, there are a lot of options that can be really confusing. People are trying to sell you a lot of different things. And so we provide just that basic information. We try to help you sort out what it is that you'd want. We're not selling anything, so we can help you with an unbiased referral. We also do a lot of Medicare counseling at this time of year for the enrollment, for the open enrollment for Medicare Part D, the prescription drug coverage. Every year you can re-enroll or take a different drug coverage, and so it's something that we do a lot of counseling for that. We also have the Caregiver Education Series right now. I've left some flyers. It actually starts this weekend, Saturday, September 27th, and we have another Saturday, October 11th. And we are going to be providing a lot of different workshops those days. It's free. It's at Sherwood Oaks Church. Our partners are IU Health, Purdue Extension, and Comfort Keepers is also providing free respite care. So if you're interested, the time is 10:30 to 2:30, and if you're interested, I'd like you to register with me so we would know how many lunches to order. It's free lunch. It's a great series. We do this once or twice a year, and so if you can't make it this Saturday and would like to join us next Saturday, that would be great. But we do that. Case management is something that we provide at Area 10 for when people need in-home services. There are some funding sources available for in-home services if you need assistance with daily living, activities of daily living. So if you're eligible for Medicaid, that you can get some help to pay for that through Medicaid or through the choice waiver. The other suggestion I might have for payment of in-home services is the VA aid and attendance care. They provide a lot of, that's not really a reimbursement as such, but it's a pension. But we can talk you through, the case managers can talk you through what some of those different options are. So if you're looking for help in paying for care at home, give us a call and we can see what you might be eligible for. We also have the long-term care ombudsman with us. That's Bert Clemens right now, and he goes to the long-term care facilities and talks with residents and makes sure that people are getting the care they need there. If you have a loved one at a long-term care facility and you don't think their rights are being respected or you don't think their care is as good as it should be, there's always a long-term care ombudsman available. And we can get you connected with him if you would like to resolve a complaint. Area 10 Agency on Aging also owns 2 apartment complexes, one in Edgewood Village in Ellettsville across the street from our building, and also up in Cunot, northwestern Owen County. And we manage Dodds Wiley Apartments just down the street from here, between Dodds and Wiley, just next to the hospital here, for Perry Township. And then we provided some support for Patterson Point, which is on west, just off of West 3rd Street on Patterson. We worked with a for-profit company, Miller Valentine, and they just built some new senior housing there. And because we assisted them, they were able to get some grant funding for the building. And all of the appliances there are energy efficient as a result of some of the grants that they were able to apply for with our partnership. We also run a lot of nutrition programs. What's the difference between Meals on Wheels and Area 10 Meals? Meals on Wheels comes through the hospital here, and they serve people who need just short-term as well as long-term meals at home. And they serve Bloomington proper. Outside of Bloomington, they don't go beyond that. And they do charge, I think it's $5.50 a day. Is that right now? And you get a hot meal and a kind of a little bag lunch for supper. But a lot of the folks that we serve at Area 10 are not able to make that payment of $5.50 a day. So we serve people in Bloomington, and then we also serve people outside of the city of Bloomington in Monroe County and Owen County. We serve approximately 175, 180 meals a day in the two counties. We also have some congregate meal sites at Pete Ellis Drive in the apartments there at Cambridge Square, and we just opened up a new site at Bloomington Housing Authority on the north side. We have a couple of restaurant voucher programs through that as well, and Village Inn in Ellettsville and the Steinsville Cafe. Those are open to anybody over 60 in the community. We also have some senior farmers market vouchers in the season for low-income seniors, and we do a food pantry program, which is if you would normally go to a food pantry to supplement your food needs because you can't afford to buy all the groceries you need, but you're homebound because you're older or you're a person with a disability, we bring 2 bags of groceries a month per person in the house, per adult in the house to you. We serve approximately, I think it's 300 people now in Owen and Monroe counties. We also have rural transit. We operate rural transit in 4 counties, Owen, Monroe, Putnam, and Lawrence. And we can do some pickup for medical appointments and things. We run some express routes in between the communities, and then we also do some individual pickups for people to get to their doctor's appointments or grocery shopping or things like that. And then we have a new CAB program, New Freedom Transportation Program, voucher program, and that is a cab ride for $7.50 one way. It's about it's the only provider we have right now is E2 Taxi, but they do have accessible cabs. And it's about $5 just to get into a cab, so $7.50 one way anywhere in Monroe County is a really, a good program. So if you're an older adult and can't use rural transit or you're a person with a disability, you'd be eligible to apply for these New Freedom vouchers. You have to pay for them ahead of time, but they have about a 60-day expiration date on them. So they're a nice option for people who maybe can't use BT Access all the time or want something else. The Enright Center is our adult community center that we have out in Ellettsville. We've got lots of activities going on out there all the time. We have a fitness program that you can join the fitness program. It's $25 a year to become a member of the Enright Center. And everybody who works out there is at least 50. We don't let anybody under 50 use the equipment. So you don't have to worry about exercising next to the 20 skinny person. Okay. But so you can get a personalized fitness program. We have a fitness specialist that can help you learn how to use the equipment and get stronger. And we have lots of great stories about people who have improve their balance and their strength and recovery fitness-wise. And then we run a lot of art classes, and there's a very fun senior singles club going on right out there now. They meet 2 or 3 times a month, once at the Enright Center and a couple times out in a restaurant or something in the community. So lots of fun things happening at the Enright Center. We also manage the RSVP 55-plus volunteer program, retired senior volunteer program. Lots of folks are registered with us. In fact, we have 450, probably almost 500 now volunteers registered through us and that work at over 100 different local nonprofits. Caring Companions is one of our signature programs through RSVP. We provide a kind of a one-on-one match with a senior, a homebound senior that just needs that friendly visitor, maybe somebody to make that phone call to them, maybe somebody to come once a week or a couple times a week to walk their dog or do some light housekeeping. And we have, I think, over 100 people matched right now with volunteers, and we're always looking for people who like to do that kind of thing. But if you're, as a caregiver, need some support like that, might be a good thing for you to try. The repairs team is also another one of our RSVP programs that we really like. Several years ago, we made a big mistake and we called them the handyman. And they said, we just do so much more than that. So they came up with their own name. They call themselves the reliable experts providing accessibility, independence, repairs, and safety. But they really do. They build ramps for folks. They come in and put in those grab bars. They, change your light bulbs. They, make sure you've got a working smoke detector. We do a lot of different things for folks with that group. And so we really love what they do. I also wanted to tell you about a couple of other things that I didn't have a slide for, I don't think. Yeah. Caregiver support group has started. We have on first Wednesdays, the first Wednesdays of the month at the Enright Center from 4:30 to 6:30 is a free caregiver support group. Homestead Senior Care does provide a light meal and respite care if you need that. Otherwise, it's just a nice group of people that meet to provide support for one another as caregivers. And then I also wanted to let you know about an organization that has a lot of good information on their webpage. It's called wiserwomen.org, and it's WISER women.org. And they have a lot of great resources like this one, Financial Steps for Caregivers, what you need to know about protecting your money and retirement. So they have a lot of resources for caregivers as well as just good other financial resources for women. But a lot of women are caregivers, so they've developed a lot of resources for caregivers. So I encourage you to use those. Does anybody have any questions for me right now? Did I put you to sleep? Okay, after dinner, all right. Well, we'll move on to the next one, and if you think of something, let me know. Is that you?
Okay, so like I said, I work with the home health care department at the hospital, and so I'm going to focus mainly on home care as a resource for individuals. But of course, if there are questions that come out of that it's beyond home care, like Medicare or some of the things that I bring up, just feel free to ask during the presentation or after, whatever you think of the question. So I wanted to open up with a little vignette about an experience I had working with a person to complete her advanced directives. I went to her home, helped her fill out her living will and her healthcare representative document, and before we signed everything, headed next door to her neighbor's house. And her neighbor was sitting in her recliner, reclining, and obviously not doing well herself. It looked like she probably couldn't walk very much, and she told me such. She also complained of being diabetic and having a lot of pain management issues. Her husband was also not doing well physically and struggling a lot just to take care of of her. And that he also commented to me that it was getting really expensive the older and older they got to cover the healthcare costs, just daily living needs, transportation, all those kinds of things that can really rack up, especially if your income is limited to like a Social Security check or a pension with a little Social Security, that kind of thing. So when I visited the home, I thought, boy, they could really use home care. And I actually tried to refer them to at least some kind of home care agency, whether it be IU Health or somewhere, so that they could get the help they need. So just think of that vignette as I talk, and I'll refer back to it when I go through my presentation. I'm going to talk a little bit about eligibility for home care, the services that we provide, and then also the network of resources we can connect you to. So first of all, a person has to present with a skilled need. Like I stated in the vignette, something like having diabetes that's not controlled, and then perhaps even like a wound on the foot due to the diabetes that needs some wound management in the home is something that home health is definitely able to care for. Or another example would be somebody who continually has balancing issues where they sometimes fall and could really use some help with that, maybe some physical therapy that would come into their home to help them. So once the skilled need is identified, then you have to have an order from a physician, preferably a physician that you work with fairly frequently because we like to be in good communication with them. And then a payer source. So you have to usually need Medicare, Medicaid, or both, private insurance, and then some people do come in as self-paying. However, it is not an inexpensive kind of support, so it's best if you have some kind of insurance. And then lastly, one of the biggest criteria is that a person be homebound, except for medical appointments, and then therapeutic outings, which can be defined as like going to church, getting your hair cut, going to a wedding, a funeral, that kind of thing. This is a list of all of the disciplines that are available through home care. The two main ones are nursing and physical therapy that serve as sort of the case managers for a patient. And once they are there managing, then the ancillary services like occupational therapy, speech therapy, dietitian can come in and help. A home health aide can serve mainly with bathing for a short amount of time until a person either can figure out kind of a way to manage on their own or have enough occupational and physical therapy that they really can just do the bathing. And then, of course, social work, which I'm always a big fan of. So a network of resources. What do I mean by a network of resources? Well, it's a connection of people working towards a greater end of better health for a person. So the primary concern is that your doctors are talking to each other, your doctors are talking to us, and we're talking to you about getting you or your loved one back on their feet. We also work with other providers and assistance programs like Area 10 or durable medical equipment places to try to get you the things that you need in your home that can really help you stay in your home for as long as possible. And then we just inherently provide caregiving service because we're there weekly. You know, if somebody has nursing, physical therapy, occupational therapy, and home health aid visits, really we could be in like 10 times a week bothering you. And it can get really, really terrible, let me tell you. But no, it's good. It's a good form of support. So other resources that social work primarily focuses on include focusing a lot on caregiving needs. If you think back to the vignette that I opened up with, a lot of what I was thinking with for the couple was that, man, they really need to see Area 10 because given what they've said just in passing about their finances, it kind of sounds like they might qualify for some state assistance through a Medicaid waiver. And it kind of sounds like they could use Meals on Wheels or home-delivered meals. Not to switch it up with the Meals on Wheels to the hospital. And then I also thought they probably need to look in a little bit more to really what's going on in the household, emotionally, that's tied to all their physical ailments. So a lot of what I look at are the formal and the informal supports, like the formal supports being Area 10, caregiving agencies that hire people to be caregivers that can come into your home, or people who are caregivers privately and that they are self-employed as caregivers. And then also having like a family conference to try to figure out what family member can be here when, so that the primary caregiver can go get her hair done or go to the doctor herself. Looking at emotional and mental health concerns, like providing some resources about support groups, some local therapists, because sometimes that's needed both for the caregiver and the person who we're treating. And then geriatric case managers and other social workers that have a specific niche in the community, like Kathleen Weber, for instance. Her niche is Alzheimer's and dementia. So a lot of times I refer her for patients that that have that disease. Sometimes staying at home becomes apparent that it's not the best thing for a person. And so if that is the case, then we can look at day programs if someone needs to be cared for during the day at least. We can also talk about a rehab placement or a long-term placement in a skilled nursing facility, what that would entail legally and financially for you, what it would look like, how long a person would be there, what Medicare would pay, what they won't pay, what Medicaid would pay, that kind of thing. We can also talk about assisted living facilities, which are, for some people, a really good answer to having some isolation, just being stuck in your home. It just provides a natural community for people to be living in assisted living. And then finally, what it seems like life is based on, legal and financial matters. A lot of times, like I mentioned in the vignette, people struggle financially with the increasing health concerns that they have, getting all the hospital bills, plus on top of it, being pretty strapped for just their income. So we can look at local nonprofits and agencies that can provide a little bit of assistance, either paying a bill, helping with meds, maybe cutting down on the electricity with some weatherization, like Area 10 has a weatherization program. And then sometimes I refer to elder law attorneys to help with Medicaid planning, something that a lot of people do in the end need towards the end of their life, because it is astronomically expensive to need 24/7 care. And a lot of times the one way to have the care provided is through Medicaid services. And then just general estate planning. Many people have not reached the point yet to doing that completely and need some recommendations on how to complete that. And finally, last but not least, assistance with advanced directives, which we provide free here at the hospital, and I really try to promote with every patient that I see, because it is such an important tool for caregivers and for the people that I'm seeing, the patients. I provide one-on-one support in completing a healthcare representative document. So that's the document that states who you want to make healthcare decisions for you if you can't make those decisions for yourself at any point. And then a living will, which is a statement that describes what you want if you were to need life-prolonging treatments. And then also sometimes POST, which is a newer advanced directive that stands for Physician's Orders for Sustaining Treatment. It's actually a doctor's order that can serve as a more fleshed out version of a living will, in that it lists exactly what you want for your treatment at the end of life. So we begin writing these documents together, and some people think that they can be finalized right then and there with just my assistance. Other people want the assurance that it's a fluid document and it can be changed at any time, which is a good thing because health conditions change, our lives change. So we usually, complete it, and then we send it to doctors and the hospital, that kind of thing. And then it's just a great tool because it opens up the discussion of what you want for your health care, and it lets the caregiver know exactly what decisions they need to make if the time ever came that they had to make them without the patient that I'm working with. Do you have any questions before we head to the next panelist? Okay.
Good evening. Am I holding this okay? Can you hear me? All right. Nobody ever tells me to pipe down, so I figure I'm all right. Happy to be with you here this evening. And I'm not going to present a PowerPoint, but I am going to try to focus on a few specific things. Sonia asked me to really focus on Alzheimer's and dementia, so I want to talk with you specifically about that, and then I want to talk with you about some therapeutic resources and some geriatric care management. So those are the three primary areas I want to cover with you this evening, along with resources. And for those of you, as you were coming in, there's a 4-page stapled resource handout on the table up front. Or in the back now as you're leaving that you can grab. And some of the things I'm talking with you about are fleshed out a little bit in those handouts. So the first thing I'm going to talk about is the question that I get asked everywhere I go, and that is, what is the difference between Alzheimer's and dementia? And it's a great question, and it's the most commonly asked question. So what I want you to think about is an umbrella, and that is this overarching word dementia. So if you think of that umbrella and you think of the word dementia, each panel on that umbrella, each color, if you will, maybe on that panel, is a different kind of dementia. So about 70% approximately of the panels on that umbrella are going to be dementia of the Alzheimer's type. And then there are a few other ones that are very normally occurring and most commonly diagnosed. And those are vascular dementia and Lewy body disease. Has anyone heard of that? Lewy body, L-E-W-Y, body. So that's not Alzheimer's nor Parkinson's, but it has facets of both of those two diseases. And those are the three most common that you're going to hear about when you hear the word dementia. And dementia really is an overarching term. It's not a disease itself, but it's a word that describes a group of symptoms of neurologic ongoing decline, deterioration, that affect mood, thought, memory, motor function, behavior, things of this nature. So when you think of the word dementia, you'll hear some of your friends and family say, well, the doctor said Gloria has dementia. My question is, what kind of dementia does Gloria have? And that's a very important question to know. And a lot of times, families don't have that information. It's sometimes very complicated to diagnose any kind of dementia. And it requires time and multiple appointments, attention to detail, good communication with your physician, good diagnostic testing. And so one of the questions then that comes up with families is, do we really need to know what kind of dementia? because we know this is progressive. We know it's affecting these different facets of the person that we love. Does it really matter? And my answer is yes. It matters a lot, because each of those diseases function differently. They cause different symptoms. They progress in different ways. They cause different sets of challenges. So it is important to understand what you're kind of dealing with. Just like you would need to know, what kind of infection you have. They'll often test that so they know what kind of antibiotic to give. Or if you think of having cancer, a physician tells you you have cancer, what's your first question? What kind? Where is it? What can I expect? What kind of treatment do I need? And all of those answers depend on the kind of cancer. Your treatment depends on all of these very nuanced factors about your unique body and experience with this illness. So it's very important to understand the kind of dementia that you're dealing with. So that need for a good and accurate diagnosis is important, because whether folks choose to admit that they're facing a change or not, and that's okay, we don't have to accept that we have dementia when that happens. We're asking for a lot when we ask people if they just face it. Some people that I work with face it head on. This is an early diagnosis. This is what I understand about it. I want to know everything I can. I'm going to plan, and they really head in. And other people say, you know what, I'm not going to think about it. I don't want to know. So in those cases, getting a real specific diagnosis can be pretty challenging. But there are good reasons to understand. So treatment is one of those things, because we commonly, I think the common thing I hear is, well, they say there's nothing we can do. And in truth, medically speaking, at least medication speaking, there's not a lot, but there are some things that work very well for some people, at least for short periods of time, and they can be well worth the time and effort that it takes to try those interventions and those medications. So the plan is really driven by the kind of diagnosis that you have. It can drive treatment, and it can drive the completion that Leah talked about of advanced directives. When anyone has a diagnosis of any kind of dementia, it's especially important to complete advanced directives in the early stages of that disease process if they haven't been completed, or you might want to amend those. Talk with your family and physician. What does this new information you're giving me mean, and what might I want to adjust in terms of my plans and my philosophy of receiving health care, and have that reflected in my advanced directives. And we want you to do that while you're fully intact and very capable of processing all of those different pieces of information and really clearly articulating to your physician, your care partners, your medical providers, all of us, your social workers, what you want, because it's our job as your team to help you carry those things out. And when you're feeling a little loosely tethered to your thoughts, you need support and help to do that. And if we have had those conversations, we can go forward with respect for you and confidence in advocating for you using that advanced directive tool. It's very important. So another good reason to have a diagnosis is getting the right education. So you want to know everything you can about what you're dealing with, because you're going to have the most tools and the most resources. If you know, education is really key. Knowledge is important in this disease. So education can help support the caregiver and the individual in doing all they can for themselves. We often, I think, have a stereotypical image of what someone with Alzheimer's disease looks like. And my experience is that's not wholly accurate. I work with many people who are very, very and very insightful about what they need, what they want, and that might be at times fleeting. Maybe on Tuesday morning it's not real clear, but on Thursday morning it's super, super clear, crystal clear. And we really want to support, my role as a social worker is to help support people in adapting to as much of that disease process as they can. It's true what they say, use it or lose it. That's true for all of us. And we all want autonomy, we all want independence. We all need to do as much for ourselves as we can because we want to, and that's part of our human condition. And it is possible. Sometimes families sweep in and they want to be super helpful, so they're going to take over mom's finances and she shouldn't drive anymore, and they're going to manage her schedule. And that is so loving. It's also sometimes just the wrong thing to do. And so now we have an argument between the kids and the parent about autonomy and what's really needed. So we want to gauge that slowly. And then there are times, quite certainly, that folks don't have good insight into what's happening with them, and families do need to really take a more assertive role for folks. But supporting education is a key factor in that. So helping family members plan, respond, and feel validated in their role is also a really important piece, and education can help that. Because if you're just shooting in the dark, well, mom has dementia, and I think this is why she's doing this, you can really be wrong and make a lot of assumptions, and you can both be in a hole pretty quickly doing that. Whereas if you really understand how the disease acts on the brain and what's happening, you can say, oh, that's why that happens, so this is how we can adapt. One of the conversations I have with families a lot is about throw rugs in the house, because I'm going to use my grandmother as an example. My mama loved her throw rugs. But as her dementia progressed, she was not able to tell the difference between what was solid floor and those throw rugs. So she would trip. But the other thing that happened is if there was a dark throw rug someplace, she began to think that that was a hole in the floor. So you'll often see people, walk, and they'll come to like a floor mat or an entryway, and they'll just stop. And that's the right thing to do if you think you're about to step into a hole, right? And we're coercing, and we're saying, come on, let's go. And really, they're using pretty sound judgment of, I see a hole, you're asking me to step off into this hole, and I'm not going with you. So if you understand Alzheimer's disease and you get good education, you can understand that that's a visuospatial manifestation of the disease that can help you modify the environment and modify your interaction with that person. So you can get the person out the door to the appointment, and there's not a battle in front of the floor mat, and that person can feel more safe and confident leaving their house because they don't have to try to hurdle this hole right by the front door. So that's just one example of why education can be really helpful and important. So there are lots of good reasons for the need for education and counseling, including facilitating sometimes very difficult family conversations. How many of you have had one of those around healthcare in your family? They can be simple and they can be easy, or they can be really painful and really difficult, especially when not everybody's on the same page or working with the same information. So that need for family education and counseling can be simply someone like you're seeing here to sit down and talk. Just sit in your living room or sit in the office, get everybody's input, and help just mediate a conversation. What are the goals? What do we all understand about what's needed here? What education and resources are available? How do we get a plan put in place? And what working agreements are we going to leave and move forward with to make this a more supported situation for everybody? So talking about changing family relationships is important in those counseling sessions. And I already referred a little bit to having a good understanding of the disease, and that education sometimes is also important just in real time. We can only absorb what we can absorb. And I learned many years ago working in hospice from Leah's mom that one of the most important things I needed to understand as a social worker is that we can't take people where they are not ready to go. And that's really okay. But it also means that we need to be ready when they're ready so we can help for that with that next step that they need to take. So I want to really recommend here for that education. Can't say enough about social work. Cannot say enough about Area 10. Did you hear that list of things Mary was talking about? The folks that work at Area 10 are so community driven, and they will go to the end of the earth to help you find the information that you need and to get you with that right person. Support groups. I want to talk about the real importance of support groups. Most Alzheimer's caregivers, the majority of people who caregive for a family member with Alzheimer's, say that support groups have been their number one best resource. That's tremendous. So you heard Mary talk about a caregiver support group. It's not Alzheimer's specific, and that's okay because any support is better than no support, and they can help point you in the right direction. We have a couple of wonderful Alzheimer's-focused and dementia-focused caregiver support groups here in town. Dana Thompson, who's the Alzheimer's educator here at the hospital, facilitates those, and information about those. On your resource handout, I've given you some information about that. And there's also Alzheimer's Resource Service handouts on the table down here on the resource table. So there's good places to get support. We're starting, in my practice, we're starting an art therapy-based caregiver support group. We're going to do 6 weeks of making messes while we talk about hard things, so we don't just have to sit and look at each other, because that doesn't work for everybody. It's great for some people, but we're going to try something different. So just find a support group. The Alzheimer's Association, I've given you their information on the handouts, and they can direct you to support groups all over the state and all over the nation. They're very well connected, and they have a lot of support groups. So the next thing I want to talk about are therapies for dementia and Alzheimer's, and I'm going to include social work in this. I've spoken about social work already a little bit. Leah's talked a little bit about social work. And so just having that counseling and ongoing support and education is important, but other therapies are really, really valuable. So I want to talk about speech-language pathology. How many of you are familiar with speech pathology? Have you ever worked with somebody or needed that service? So a lot of people think, at least I find this, a lot of people think of speech pathologists as somebody who helps you when you have a swallowing problem. That's the typical thought. You've had a stroke, or you've had kind of a change that requires some help with this. So you're going to talk with us about swallowing and about maybe putting things in a blender, stuff like that. Well, in truth, speech therapy does so much more than that. And for the person with dementia, it can be a really remarkable service. So speech-language pathology can help with communication strategies, increasing verbalization, keeping one's mind sharp. At Better Day Club, which is a program that we offer a couple days a week, we work really closely with IU Speech and Hearing, the clinic at the university, and they come and do, we call it cognitive weightlifting. And it's a couple of hours of a lot of fun, highly social engagement, and no one really thinks of it as a clinical service or like they have been in therapy, but I'm telling you, it's phenomenal. We laugh, and at the end of 2 hours, we're pretty cognitively tired. It's time to move our bodies and take a break and stop thinking for a while. And historically, speech therapy intervention for Alzheimer's disease really does show improvement in people's cognition in the hours and days surrounding that treatment, and also just in terms of helping people really hold on to what they have. So that's one of the things that speech-language pathology offers for this disease that I think we often overlook. Occupational therapy is really paramount in managing dementia. It includes everything that you would think of, like dressing and bathing, eating, personal care, to also things that you just enjoy doing during the day. If your thing is reading the newspaper and you really are struggling with that because visuospatially you can't figure out how to get the newspaper open and you're not interpreting language as well as you did, they can help with strategies for that. If that floor mat that we were talking about is looking like a hole to you, we can work with occupational therapy and help you come up with strategies to change the environment to help you feel more independent and more safe. And it's really a key piece in retaining and adapting your ability to continue doing enjoyable activities and just functional activities of daily living. Physical therapy, I think we know more about. That's really about balance. It's about strength. It's about fall prevention. Definitely maintenance after rehab. One of the phrases I talk about with families is it's never just Alzheimer's. Right? There's always more going on. We bring our whole family picture and our whole physical and medical picture to that disease because none of us are getting any younger. So we may have other illnesses like diabetes or a hip replacement or something to manage along with Alzheimer's, and that can get pretty tricky. So OT and speech and physical therapy can really help with that, including caregiver training, which is, I think, something that's very important that we don't often think about in terms of those disciplines. They can help with back safety and safe transfers and how to assist someone more effectively so they have more independence, which is helpful for the caregiver, right? Because if someone can do more for themselves, the caregiver can get a little bit of a break and maybe actually eat lunch with their partner instead of helping their partner eating lunch and then eating alone. And that's pretty important. So, primary issues beyond a good diagnosis and education and beyond those therapies are safety. I talk a lot with families about safety and autonomy. Where's that line between mom being really safe to stay at home and having her independence? What is the level of risk we're willing to tolerate? What are the things that we can put in place to help this situation and to hold her where she is as long as possible? One of the hospital has two phenomenal services that I refer to truly almost daily, and I cannot say enough about them. And they are the Home Safe Home Evaluation out of rehabilitation and sports medicine, and that is an occupational therapist who can, with a doctor's order, generally billable to Medicare, not always, but almost always. I think we've now really figured out how to nail that down with Medicare. Can come into your home and really walk through your day with you. Look at your environment, make recommendations about modifications, change a bathroom around before you have a contractor come in and make changes. That is an incredibly valuable service. And they look at from the very small things to the very big things. And it has saved families I work with truly thousands of dollars in remodeling costs. Really targeted interventions beautifully, and they are a pleasure to work with. I highly recommend that service. The other service I want you to know about, and those brochures are down here on this table in front as well. Leah brought those. I emailed her and said, will you bring them? I don't want to give up my stash. Will you get more of them? The other one is a community mobility assessment. AKA driving evaluation. So driving is a big deal. It's a real challenge. And a lot of times, and accurately so, as soon as someone gets diagnosed, the family says, Mom, you got to give us your keys. Well, that's a blow. In our society, we're not a real walkable society. And so our driving is really a key piece of our independence and autonomy. So the discussion I have with families is, before we talk about taking the keys, let's talk about what we're going to put in. Let's put in supports for transportation before we take this piece away, because it's so hard. So again, rehab and sports medicine here at the hospital has this community mobility assessment done by an occupational therapist. Rachel Norton is one of the most gracious and good clinicians that I have ever met. And she's kind about this, and she's just astute. It's a 2-part evaluation. It can be ordered by the physician, and again, Medicare billable. The first part is in the clinic, so no vehicle, no road driving, none of that stuff. It's a cognitive assessment. They look at problem-solving, judgment, response time. It's physical and cognitive. And then depending on how that goes, she can make a plan to help you if there are some things that need modified, that can be changed around, that can help you drive safely for a while. They're going to target those and look at that. For some people, it's not safe to drive, and I need to send a letter to the BMV, and we need to make some changes. And for other people, it's, this really went okay, but we need to look at the whole picture. So let's schedule for you to come back and take a road test and go out actually on the road with her in a car that has controls on both sides, and do that driving evaluation on the road. That's a really great service, and those brochures are down here as well. Then I want to talk about, go back for just a moment to that. If you don't use it, you lose it. Staying active is a key piece of this disease. So whatever kind of dementia you have, just moving your body and engaging your mind and having some social input is so important. This is a very isolating, the dementias, I will say, are a very isolating set of diseases for caregivers, and especially for the person with dementia. They lose the ability to socialize in unsupported situations. A lot of the ways that I assess folks for do they have dementia or not when families are on the fence, I start with, what do you like to do? Where do you go? What does your social life look like? And if I talk to somebody who hasn't missed Sunday school for 35 years, and now they just don't feel like going, and they're saying, I don't feel good, or the weather's not good, or this or that, I start looking, because a lot of times that actually points to social withdrawal. And when I hear you really love and are a part of a community and you start to withdraw from that, we need to look at what's causing that and how can we help you reconnect with that if at all possible. So staying active, staying engaged, everything, the End Right Center offers so much for folks in terms of programming at a very affordable cost. Even if it's just getting out of the house a little bit and taking a walk. Through my practice, we have Better Day Club, which is 2 afternoons a week for 4 hours of the speech therapy I was talking about, art therapy. We make huge messes. It's awesome. No one has to clean up their mess. I get to clean it up. And I don't even mind because we have so much fun. So whatever it is, find a place to plug in and find some help in figuring out how to adapt so you can stay plugged in. And then I'll talk just a minute about geriatric care management, which Leah alluded to. This is a professional role. A geriatric care manager is a professional role usually held by a social worker, a nurse, or someone of a similar background with training. And this is a person who can step in kind of as a coach and help the family be the primary care team, kind of using the care manager as a guide. That's more the type of service that I provide in my practice. I don't sit down and do one-on-one counseling with folks from a mental health standpoint. I sit down in your living room and we talk about what's working, what's not, what do you need, where are the holes, where are the gaps, what resources do you need, how do we do advanced planning, do you need that legal financial planning, what do we need to plug into at Area 10? Okay, now, you've got 3 kids sitting here with you. I'm here. You're able to do some things for yourself. Let's start parsing this out. How are we going to get this plan done? What's right in front of us, what's intermediate, and what's that long-term plan? Where's the roadmap? So my goal is to come in for a short period of time, help you with that map, and then leave you with it, and you can check back in with me. Some geriatric care managers, I really think of more as kind of a daughter on the ground, if you will. And no offense to sons, but women are often the primary caregiver and the people who pick up that role. I will say, in support of the guys, that the majority of the caregivers I am working with right now are husbands. and they're really doing a good job. And from everything from how buying a bra for your wife is not a simple thing. It's really, I mean, we've laughed about that in some of our groups, but the truth is that's a hard thing to do. And these gentlemen on every occasion and every situation are rising to the occasion. But part of the reason they're able to do that is because they're not scared to raise the white flag and go, wait a minute, I can't do this. I have no knowledge about this. What do I need and how can we get help? So they can do it. But that geriatric care manager can be a person who can be as hands-on as you need them to be, attending physicians' appointments and taking notes and disseminating that information to the family who maybe lives out of town, to managing medication, getting home care in place. In some cases, they sit down and help people manage their finances and write their checks and get their monthly bills paid, can meet with their financial trustee and help manage finances. They can coordinate, the daily schedule. Who's going to be here when? Who's going to take you to which appointment? How are these things going to get handled? We want to make sure you get to your Bible study. We want to make sure you get to your book club. How's that all going to look? Let's talk to your friends who can do a carpool. So, it really can be whatever you need it to be. In terms of paying for those services, we talked about things get expensive, right? There's not a lot of insurance that covers that. So it tends to be private pay. And there are some long-term care insurance policies who do have some coverage for that available. But you're seeing that more in the newer policies than in the older policies, is what we're finding. So folks that are just in their early 60s and maybe have had a policy, because they saw that their parents could have used that and signed up for one, theirs might. But some of those policies that are, 25, 30 years old don't have those kind of coverages. So any of us are willing to help you figure out what is in your policy and what it covers, or find the right person to help you do that. So sometimes we just got to get on the phone. I had a good friend who called and said, in fact, when I worked at the hospital, she volunteered with me for years, and she was amazing. And she always said, whenever I need anything, I'm calling you because you're dogged on the phone with those companies. And I said, okay. So she called me one day, and she said, I need you. I've got this policy, and I need to use it, and I'm tired, and I need to figure it out. Will you come over? And I said, you betcha. And we spent 4.5 hours on that phone. But by the end of the afternoon, we had the first step of it done. It only took us like 3 more days on the phone, but we got it done. So geriatric care management is an amazing and remarkable tool, I think, for families, and can take a huge part of the burden off. I know what I hear a lot from families is, you said exactly to my parents the thing that I've been saying to them for 3 years. You used the same words. You said it the same way. And they said, wow, Kathleen, that's a great idea. Yeah, we'll do that. And, we'll be out in the driveway having this conversation, and then they say, I want to now kill my parents. I'm so angry that they listen to you and not me. And you know what? It's really okay, right? We just get there when we get there. Sometimes when my husband tells me things a few times, I don't really listen. But when one of his IT friends tells me the same answer to my IT problem, I go, oh, that's great. I love that. Hey, John, did you know this? And I get that look. So in terms of resources, one of the things you should know is that the best way to get a good assessment and a diagnostic workup is from a neurologist or from an interdisciplinary clinic. And that can be challenging because it takes a long time to get a neurology appointment. Thankfully, we have 2 new neurologists in town. So Jamie Bales and Brian Moore, who are phenomenal, and Dr. Way, who's lovely, are getting a little bit of help, and they need it because we need an army of neurologists with the numbers with this disease mounting. And so Leah made a lovely list of all the neurology practices in town, and it's on this table over here for you. And I encourage you, if you have any concerns about this, to talk with your primary family physician, get a referral for a neurologist, and be assertive. If the person that you love goes to their primary family physician and for 20 minutes is wonderful and can answer all 30 questions on that mini mental status examination, and just the doctor says, I don't know what you're talking about, your mom and dad are fine, but you know they have delinquent notices, they're having car dings in the parking lots of the Kroger store, things are changing. Please, please be assertive and ask for that referral to a neurologist. Teasing out a diagnosis takes time, and it takes a lot of persistence sometimes. So I encourage you to do that. There are some good interdisciplinary clinics in Indianapolis. I refer a lot to the IU Neuroscience Center. That's a good place to get an evaluation, and they kind of can look at the whole picture. And especially when you're dealing with a dementia that's harder to diagnose even than Alzheimer's, like Lewy body disease, you might need a what I call a super specialist, somebody who sees a lot of that instead of just a little of it. So Home Safe Home, driving evaluation we talked about, the Alzheimer's Resource Service through IU Health. On the resource page here that you'll find in those packets on that back table as you leave, there is a list of Alzheimer's Association, the Lewy Body Dementia Association, and some other things there that will be numbers that you can get some immediate support and help with. And I thank you for listening. I'll hand it over to Catherine. Any questions? I'll stay after.
Thank you, Kathleen. My name is Catherine Boltman, and I am a clinical social worker here at the hospital. I work with the palliative care team. I've been with them for about 6 months now, and prior to that, I was the social worker with critical care and cardiovascular services last 5 years. You guys have had so much information thrown at you. I'm not going to weigh you down with tons of lists, and certainly the lists that we have are available and, wonderful to take with you so that you can, remind yourself as you go along. I suppose you could say that I'm going to talk to you about, certainly another issue that we all eventually face, and that is, working with the palliative care team. We often see people when they are dealing with very challenging or very complex chronic illnesses, or some people with life-limiting illnesses. And our goal is to really look at the global picture, and that's the patient, that's their family, that's their caregivers. It's really their whole environment that we want to pay attention to. Leah had sent me the link to a recent study by the Institute on Medicine called Dying in America. It's the latest study that's been done. And the one, I did not get a chance to read all 500 pages of it. Okay? It was a little too much to do. But, one of the really interesting things that came from this was how one of the most important facts they found is that it's the psychosocial issues that are coming up with chronically ill patients that is one of the biggest problems we're facing. That we need to not just look at the disease, not just look at the pain or, what surgical procedure we can do or something like that. We need to look at the whole person. So our team, the palliative care team, we really look at, certainly we address issues of pain management, any sort of physical distress. But then we also want to talk to the patient and find out who they are. We'll sit down and meet with the family, what do you like to do? What did you used to do as a career? What do you presently do? We get to know the whole person, psychologically, spiritually, physically. We want to address all of those issues because that's an unmet need that's, continuing to occur. Maybe sometimes a good way to illustrate is with a story. So I'm going to give you a little vignette of a patient that we worked with. Take my glasses off because I have not quite gotten to the progressives area of my life yet. I'm afraid I'm going to trip. Okay. So this is about Mr. G, who was admitted to the hospital after a suicide attempt. He'd been diagnosed 2 or 3 months earlier with an advanced cancer of an unknown primary. And he had begun chemotherapy and actually had a wonderful response. His tumor shrank to almost nothing. So he had a great response. However, he had a 40-pound weight loss. He was so weak. He had no appetite. He couldn't take care of himself anymore. And he felt as though he'd really lost part of his identity. He had a daughter who had 2 small children of her own. So he had really very limited social supports as well. He was sort of new here in town. Became so distraught that he decided that he would rather end his life than continue, feeling each day as though he were less and less of a person. And he didn't want to burden his daughter with the care that he now knew he needed. So he came into the hospital, and the doctor referred him to our team, and we went and met with him. The first time we met with him, he was laying in bed and tearful and just completely distraught. So we talked to him, just, where are you today? What's going on? And just talking to him as a person. Who are you? Where do you come from? What do you like to do? Just to develop that relationship with him. He ended up perking up a little, I think partly because of the social contact, because it wasn't somebody just coming in and listening to his heart and his lungs and, prescribing a few more things. It was somebody looking at the big picture. Because he'd had such a positive response to the chemotherapy, we worked with him to figure out what were his goals. Well, first of all, he wanted to feel less sick all the time. He wanted to get an appetite back so he could get his strength, so he could actually walk around and take care of himself, because that was really important to him. Also, he was very depressed. So, we looked at, getting him on some supplements, getting him started on an antidepressant, which he was open to. And he knew he couldn't live by himself. So we assisted him in having him placed in a nursing facility that he was perfectly comfortable with that, because he knew his daughter couldn't take on that role. He left the hospital about 5 days later, cheerful, encouraged. And at first when he came in, he said he didn't want any more treatment for his cancer at all. He was done. He had decided that he wanted to proceed with chemotherapy because he did have a good positive response, and he felt more hopeful because his needs were being tended to. So when he went to the facility, he had better symptom management. He had more social interaction with the people at the facility. And his daughter was certainly incredibly relieved that her father was getting the attention that he needed. We were able to talk to her and kind of process her feelings about not being able to take her father in because she had a full-time job and 2 small children. And they had at times had a very estranged relationship. So, looking at the whole person in that situation and finding out exactly what they need, not just from a medical standpoint, is really the crux of palliative care. He went to the nursing home. He came back a couple months later after having gone through with the chemotherapy. Unfortunately, his disease had progressed. When he came back, he knew us. We knew his daughter. I had continued to have some contact with his daughter after he went to the facility. She needed information on resources for where he might live if he did gain more independence, physical independence back, and just talking about sort of what the trajectory of this disease might be. He came back to the hospital with some further symptoms that seemed to indicate that there may have been spread to his brain, unfortunately. We talked to him, and he was very open. He knew us. We had had that time to build that relationship. And he said to us, I'm done. I'm okay with that. I want to be comfortable. I know you guys will take care of me. I trust you. And we were able to facilitate a conversation with him and his daughter. She was very supportive of his wishes. She as well, we had all developed a relationship together. We were able to transfer him to our hospice house, where he was able to pass away, very comfortable with dignity and his daughter by his side. Our relationship continued with the daughter. She called a few times after he had passed because she knew she had people she could ask questions of. And again, it's developing that relationship with the patient and the family. Looking at that global picture. I think sometimes, our healthcare gets so fragmented, if you will, that we really need to pay attention to that big picture. The distress that families suffer when someone is very ill or perhaps even faced with a cancer diagnosis, can be as damaging, if not sometimes more damaging, to the caregiver than to the patient themselves. When we address the global needs, the physical, the spiritual, the psychosocial issues, we're hitting it on so many different levels that we're going to have a better result. People are going to feel like people and not patients. And so when we look at taking care of patients and the caregiver, we're trying to address everybody's needs. And certainly, as a social worker, when we're in school, it's all about the big picture. We're there to affect the entire system. And I will sort of harken back to this study that was done talking about people's needs in the home. I think it was I digress. There's a doctor in New York. Her name is Diane Meyer. She is the director of the Center for the Advancement of Palliative Care, CAPC. She's also a professor of geriatrics and palliative care at Mount Sinai Health System. And they had recently received some, so what do we want to call it? I am without my words right now. Kathleen, help me. Well, Medicare was, they had gotten some penalties for high readmission rates. And they hired a tremendous number of social workers to go out into the community to look at these patients and their families and to determine why these patients were coming back into the hospital. And what they found was that, maybe they didn't have electricity, maybe they didn't have food, maybe they couldn't afford their medications. Again, there were all of these psychosocial issues that weren't being paid attention to. And so the focus, what this group is recommending is that we focus on palliative care. We look at the global picture. And so I really want to encourage everybody to kind of think about things, in a bigger picture. Our group here at the hospital is, at this time, an inpatient service. So we see patients that are referred to us by physicians. A lot of the times we see very complex medical patients, patients with pain management issues. There are times when families know about the palliative care service and they will ask the physician if they can have a consult with our team. We really like that because that means we're coming in a lot earlier. Sometimes we get there at the last minute, and we are there just to help make someone's passing gentle. There can be, in that sense, a misconception about what palliative care is. Some people will say, oh, well, that's hospice. And it's not. Hospice entails palliative care, but palliative care is something we can use at any phase in someone's illness. Whether it's a chronic illness like COPD, CHF, diabetes, Alzheimer's, having palliative come in early to look at, what are that person's needs? Do they need support at home? Do we need to do advanced care planning? Do we need to talk about what their goals of care are? What are their values? How is this affecting the family unit? That's really what we're there to do, to get a bigger picture and to plan for the future. What our doctor always says is, let's hope for the best, but let's have a plan just in case things don't go quite the way we want them to. And so that also leads to advanced directives, which I do a lot of that with our patients, and we use the POST, and that's the Physician Order for Scope of Treatment, which is a unique document that was brought into the state about a year ago. And what that does is it's really for patients who have serious illnesses, and it goes further than a living will. It talks about really specifically what their desires are for how aggressive to be with their medical care. We talk about what's called a code status, if your heart were to stop or your lungs to fail. We talk about just how aggressive to be with someone's care. Do we want to focus just on comfort? Do we want limited interventions in terms of, if we get sick, please bring me back to the hospital. Let's do what we can to overcome this acute illness, but let's try to stay out of intensive care. And then there's also, a box where you can say, I want everything. I want you to do all aggressive measures, throw the kitchen sink at me. I'm here for the long haul. Let's do everything. We also talk about use of antibiotics, whether that should be aimed at just for comfort measures, or if we want to use that just consistent with whatever treatment goals are present at the time. And then it also talks about artificial feeding tubes, whether we want them or not, or maybe for a time-limited trial with a goal perhaps to eat by mouth again, or some people will say maybe for a month, but that's all. So, those conversations about, just how much we want to do with our medical care are, they're very detailed. They can be very, very hard emotionally to talk about. I think sometimes, going to physicians' offices, I'm not sure how many of you have had conversations with your physician about what your wishes are, or, what a good quality of life is for you. How many people have talked to their physician about that? None. It's not a big group, but I would say that more often than not, that's the norm. So, certainly the social workers here at the hospital are able to talk with you about that. Any of these people, well, Mary, I don't know if you do that. No, okay. Leah certainly does. Kathleen, you send them to me, and I'm happy to see them. But it just is about starting a bigger conversation for all of us. What's important to us? What do you need to have a good day? What do you need to have a good life? And we can talk with families and talk about all the different options that are available to do that, and get a clear idea about perhaps what you don't want. There are a lot of people who come into the hospital who are put in intensive care, have a lot of very invasive, very uncomfortable procedures done. And there are times when I will talk to families and they say that this is not the way they want it to go. But I didn't, is it my place to say whether or not we do that? And so I think we really need to start having those conversations as families, as friends, as a community, to get some clarity about that, so that we can allow people to live full lives, understand, what their wishes are, and also grant them a peaceful passing. So we have a lot of services available here at the hospital, and we have some pamphlets on the side table as well. And I want to make sure that we have time for you all to ask questions of everybody. Do you have any questions for me right now? Okay. Thank you.
Okay. So we can take questions now if there are any specific thoughts that you had in mind while we were speaking. Feel free to raise your hand or just yell out any kind of question you have.
Oh, come on. There you go. Wonderful. What form does that take? Tell us a little bit about what we would expect. So the question is regarding support groups for caretakers, what form does that take? What does that look like? So I'm going to say that first that they're free. There's not a cost for the caregiver support groups that are run by the hospital and run at Area 10. And that they are generally, the groups here in the community are facilitated by either a master's level social worker or someone with a master's degree in counseling. So they have a trained facilitator that serves just kind of as an anchor person. The groups are open. They're available for anybody. I usually recommend speaking with the facilitator before you go, but that's not necessarily always a requirement. But I think sometimes people are just more at ease if they make contact with the group facilitator first. People are welcome to attend. There are some people that will go every time it's offered for 3 or 4 months straight, or 6 months or a year, and then they're really okay for a few months and they take a break, so you can come and go. They're a tool for you to use as you need to use them. They typically are based around support and share. So folks come in, they introduce themselves. You're free to give a little bit of background about what brought you to the group. They're usually not driven so much by advice, but on just support and resources. How might you find information that you need, and just a safe space to say things and express things and question things that you might not feel comfortable doing in your family. I hear a lot of people say, I will not go to a support group. I do not want to go to a place where I'm going to complain about the person I love. And the first thing I say is, oh, you've never been to a support group. Because that's really not what it's about at all. It tends to be a pretty collaborative and supportive environment, and many people find the right group for them and stay with it over the course of years of a disease. I've had people in Alzheimer's support groups for over 10 years, and they are steadfast in attending that group, and it has helped them through that process, and they've been anchor members, of that support group. And it's just a great place you can just pick it up for a few weeks or a few months when you really need some extra support and help, or you can make it part of your ongoing plan. Does that answer your question? So different groups run differently. So some support groups, the Alzheimer's Caregiver Support Group that meets the first and third Wednesdays of the month, that's run by Dana Thompson here at the hospital, is not a theme-based group. It is strictly a caregiver support group, and she might bring in a speaker now and then, but typically what we find is when caregivers come to those support groups, they don't want a speaker, they want to talk. They want the facilitator and the speaker to zip it because this is their chance, their 90 minutes to talk. So typically there's not a theme at that support group. There is another group that she also facilitates that's a side-by-side group. So they have a group for folks who have Alzheimer's, and it's a storytelling group, and that meets side-by-side while the support group meets. And I think they do have a little more structured and thematic group there from time to time. So it would be good to check with her for the Alzheimer's specific stuff. And then Mary, talk to us a little bit about the Area 10 group.
There we go. It's been a very small group, so as of late. So people generally come in and can talk about what's on their mind, So it's usually more of a support group. I thought maybe it would be a little bit more educational, like pick a topic and then people can talk about what that topic, how that works in their life. It's just even like handling stress or handling a difficult situation. And so sometimes there are ways, but mostly what happens in a support group, I think, is that the members learn from the other members of the group. So you get ideas from the other people in the group about how to handle something that you're having difficulty handling.
Any other questions?
I'm just curious how many people in the audience are currently caregiving for somebody. Okay. Yeah.
Okay, I'm going to ask the next question, which is, so for those of you who aren't caregiving, if you care to share, I'd be really interested in what brought you here. And is there an interest or a thing that brought you here that we should speak to before you leave? Mm-hmm.
I did that for my dad, but of course, I'm able.
Mm-hmm.
And I'm able to be a caregiver for my husband or vice versa.
Mm-hmm.
Since we live in the week, and I wanted to know what resources are out there so that I can put on the file.
Planning ahead. Do we love that?
Oh,
Very good.
I can see that, yeah. Phenomenal. So she was saying that she was a caregiver for her father, but that, as all of us, she's not getting any younger, and that she has the ability to anticipate being a caregiver for her husband or vice versa at some point, and she wants to know what's available and what's out there, and she tends to be a hub and a resource person for friends and family, and so she came to find out what's what. Good for you. Love that. Yeah. Anybody else?
Well, if there are no other questions, do take a look at the resource table before you head out. Feel free to stop any of us if you wanted to speak with us one-on-one. We're more than happy to. And even if you want like our contact info, we can share that with you too. And thanks for coming.